All right. It looks like we have 63 participants in the call, and that's likely going to increase. If I could just remind everybody to please keep your device on mute. That's going to be very important to make sure that we can get through this in a timely fashion. I know it's a Saturday, so I'm going to try and do this in as short of but most direct way as possible, because I know there's a lot of questions surrounding telehealth at this time. This entire session is going to be recorded. So anything you say, if it's out loud, will be recorded. After the end of this will also go to the Medical Association of the State of Alabama so that they can post it and download it. If you could note that there is also a chat box. So if you have a question that you'd like me to attempt to answer at the end, I'll be the first to say I don't have all the answers. But if you could just type that question at the bottom in the chat box. Alternatively, you can wait to the end and do this verbally, but with the amount of folks that are on this, it might be very difficult if everybody tries to ask their question at the same time. So the chat box actually is a better way to do it. So right now I'm going to make sure everybody's all muted. So I'm Eric Wallace. I'm an Alabama native from Anniston, Alabama, and I'm a nephrologist by training and have been doing telehealth for about 7 years in the dialysis population and in rare genetic kidney disease. Because of that, about 2 years ago, I became the medical director of Telehealth for UAB, and unfortunately, I guess at this point, I'm the director of telehealth during this crisis that we're having. So we've spent a long time, or a lot of time over the last week and a half, really trying to transform as much as possible of UAB ambulatory visits to telehealth. And based on the questions that I've been getting, even from our own providers internally, I knew that there had to be questions externally as well, as I've gotten text messages and emails from folks out there. So I wanted to make sure that we had a very quick introduction to telehealth kind of during this time. All right. So just disclosures, the views of this presentations are my own. I thought it was important to get the information out there. The other disclosure is, as this is a very fluid situation, anything contained in this presentation is not subject to change. It is actually likely to change because we are getting daily updates and daily changes from insurers on telehealth. So by the time, 2 to 3 days from now, this presentation will be out of date. But likely what will happen is the information in this will remain, but there will be more codes covered. All right. So if you guys, I think we have to at this point take the COVID-19 seriously. This is not something, although Alabama has not had the brunt of it, this will only continue, and it will continue to get worse. So I think we have to plan right now on and implement right now things to do to not only protect our providers, to protect our patients, to try and slow the spread. Notice I didn't say stop the spread, but slow the spread to make sure that we're not completely overwhelmed. Jeannie Marazzo is the head of ID at UAB, and she's been on CNN discussing the projections, which are right now cases will likely double every 2 days. So if you look at this, if we slow the spread, then 20% of adults are infected over the next 18 months, you can see the top left-hand corner, and our hospitals will probably be okay. On the other hand, if we get 20% of patients or of people in the United States infected in 6 months, then the red on the bottom is what would happen to our hospitals, that there'd be a significant portion of hospitals that would be overwhelmed, specifically on the West Coast and the Northeast. Now, on the other hand, if you get 60% of people that are infected in 6 months, virtually every hospital in the country would be overwhelmed. So right now, the goal is to slow the spread and really make sure our workforce is intact while we battle this, so that we hopefully, with planning, do not end up like Italy right now. All right. So telehealth use cases. So one of the first things is just what are we going to do with telehealth? I mean, how could telehealth actually, 1 minute, let's make sure we mute. All right, so how can telehealth actually help us? Well, the first thing is we need to keep patients away from each other and have social distancing. A hospital waiting room, an ER waiting room, or a doctor's office does not really meet that criteria of social distancing. So what we need to start doing is converting as much low acuity ambulatory visits as possible to telehealth. We need to try to keep patients healthy. So I think that there was, with all of the national emergency, a lot of healthcare providers, a lot of industry has moved everybody to the home, but we can't stop seeing patients. Our goal here and for the next foreseeable future is we can't really reduce the healthcare workforce. If anything, we're going to need more people, not less. So we need to make sure that we do the low acuity visits in the home, keep them healthy to try and prevent them from going to the ERs, because the ERs are going to become overwhelmed at some point, and they will not have the resources to handle every single patient that has a problem that ordinarily could have been taken care of in the ambulatory setting. On the inpatient, as far as use cases for telehealth, obviously telehealth has been used to expand access to subspecialty care, but right now there's even a more dire need, which is that we have to improve isolations of patients that have COVID and reduce the amount of PPE. So many hospitals, even right now, because COVID actually hit in other places in a far bigger way than us, but because of that, the PPE has been exhausted, and we are trying to see how are we going to expand the use of PPE, especially when the supply chains have been not as reliable. So telehealth can actually help us do that, and I'll show you some ways that telehealth could be used. Preserving workforce, we have to have a way to protect our workforce, because if workforce gets quarantined, now all of a sudden we don't have anybody to take care of patients. So we need to use telehealth to provide the best care possible while maintaining a workforce that is able to care for the patients that will be coming. And we need to use it to improve our efficiency. So those are just some use cases. One of the big ones that I want to talk about right now, and this is what we are doing in every one of our emergency rooms, as well as we have an emergency room for maternal cases. So what's happening now is that there's a significant amount of patients that are coming in with URI-like symptoms, and even without COVID testing, given that is the fear, in order to triage those patients, you have to use PPE. So thanks to Dr. Blake Gibson, who is an emergency room physician, she contacted me early during this, and we outfitted the ERs with telehealth carts. It does not have to be cart-based, but the idea is the patient goes to pre-triage. Usually this is either a phone call or even in person, but if there is anything that is URI related, they will go to a triage room. In the triage room, there's telehealth equipment. At that point, right now, the nurse actually dons full PPE, takes vitals, and the physician actually is outside the room doing the video visit. However, what we'll be working towards doing is having ways that patients can take their own vitals just for triage. And if there's after the history, doing physicians right outside the room. So after the physician takes the history, if there's no cause of alarm or if they're very low risk, then you don't need PPE, and nurse could go in without PPE. On the other hand, if they are high risk, then everybody needs to don PPE. So as a way to, number one, improve isolation, because a video conference is better isolation than a PPE mask, but also to reduce the need for PPE. Sorry, I had to do this webinar not in my office because I'm locked out of my office because we closed down many parts of UAB for the weekend. So technology, we have a full telehealth cart. Those are expensive and unfortunately very, very hard to come by at this point because there's been a run on technology. However, you can do this on an iPad with a stand. So one way to do this in your own ERs, and I think we have to do this as a state because we need to reduce PPE, not just at UAB, but everywhere. But one way to do this in a very low-tech way is just get an iPad that the phone number to and FaceTime it. So the iPad stays in the room, you do a FaceTime to the iPad, or a Skype, and now you have full visualization so you can talk to the patient, do a visual exam and make sure that they are not, or see if they are not high risk or not. So there are ways to do this even without the full telehealth setup. Now, interestingly enough, this is going to come up. Now, what I'm about to say is only for Medicare. So if you look at how we practice medicine, and the way the billing codes were prior to COVID, the way that would happen is you'd have a hospitalist go in the morning, they would do a full physical exam. Then the endocrinologist would come in and do a full physical exam. The nephrologist would come in and full physical exam. We're not going to have the PPE in the future for that unless things change dramatically. So Medicare has already adopted these isolation exceptions. So for billing for patients in isolation, what can be done is somebody needs to examine them once. In the morning, or at least recently. So when patients come in and are examined and they are found to have COVID, turns out that the biggest thing that it's mainly supportive care with COVID. However, if they're examined in the morning and then a consultant comes in, the consultant can actually document that this is the next bullet point, that a full contact physical exam was not possible due to the clinical condition of the patient, not unlike what happens for a fresh burn patient. You can document the key findings that you can see. So if you're video conferencing with them, you can document those key findings. You can stand greater than 6 feet away from them and document, let's see. And document any key findings that they can see. And you can document the physical findings from the physician who has most recently examined the patient. So at that point, once you have documented all that, you can bill for whatever level that you would have done. So if you would have done a level 4, then you can bill a level 4. You would have done a level 5, you would have been billed a level 5. And I would also document time because although these are unlikely to be audited in this time period, at least for the next week, 2 weeks, it is our oath to actually provide the best medical care. So the only reason for doing this, and the reason I think we need to start working on changing over is this potential lack of PPE that is coming. So I wanted to get that out there because really I think the nerve-wracking thing is to make sure that we preserve PPE as long as possible. So insurance coverage, this is as of March 21, and I had a slide deck that was as of March 16, but it's already changed. So Medicare actually was probably the first to change their coverage, but at first they only covered in places that were in a state of emergency. So Alabama was not a state of emergency until Friday of last week. So it turns out that as of now, all states are in a state of emergency, and as such, Medicare will allow you to bill a level 1, 2, or 3, 4, or 5. Actually, you can bill all levels for Medicare if you're doing video visits. Now, phone visits, we are awaiting clarification. The wording of the document that has been put out is audio and visual. So audio and video is for Medicare considered telehealth. But we're just making sure that they didn't mean audio or video for a level 1, 2, or 3. Blue Cross Blue Shield also on Friday announced that they would allow telephone or video to the patient's home for a level 1, 2, or 3. So for those of us who had done Medicaid or who had done telehealth before, the home was not an appropriate place for telehealth. So all of these regulations have really changed to allow for the patient to be in their home to try and prevent them to come in. So Blue Cross Blue Shield, telephone, video, you can bill up to a level 1, 2, or 3. Medicare for phone, right now, until we get clarification, is the G2012, which is an $18 charge, but we have to get them to, if they did mean audio and visual, I think we need to push on them to change that to audio and video. But a video can bill a level 1, 2, 3, or 4, or 5, but you have to meet medical decision making. Medicaid on Tuesday of this week, their recommendation were essentially the same as Blue Cross Blue Shield, and Viva was the same as Blue Cross Blue Shield. So what you can see here is that this is now becoming very easy, which is that essentially you can do video, with the exception of Medicare until we clarify, you can do video or phone to the patient's home and bill a level 1, 2, or 3 E&M visit. Those are not billed at a reduced rate. Those are the same rates that would have been billed if the patient were here in person. All right. Since I'm a nephrologist and unfortunately, or fortunately, for the last week, I have actually had to let my colleagues see my patients, so I miss my nephrology. So for my nephrology colleagues in-center, there was never the ability to do in-center telehealth until the COVID crisis. So now you can see the patient once, and then you can get the visit 2, 3, and 4 being done over telehealth. For home dialysis, it's the same as previously. The patient has to come once every 3 months for a face-to-face, but after that, it can be telehealth. All right, so regulatory. So there's the regulatory now, and then there's the regulatory for when this is over, because we will get through this. So arguably, although right now there's been a lot of regulatory that has been waived, I would encourage everyone to try and put some structure around telehealth such that when this is over, we are able to move forward and use telehealth appropriately in the home. So Medicaid, for those of you who read the chapter of Medicaid has actually waived the requirement for providers to sign a telehealth agreement. So it used to be that in order to do telehealth, you'd have to sign an agreement, and then you'd have to snail mail it back and hear back that you were approved. Medicaid has now waived that requirement. So as far as getting ready, every provider who could have billed Medicaid before is able to now. Blue Cross Blue Shield likes to have, or previously liked to have, the tax ID of all the providers who are billing telehealth. I would encourage everyone to get your admin staff to send the tax ID and fill out the form for Blue Cross Blue Shield, even though it's not required, because I think that we need to start planning for when this is over. Consent. Now, this actually makes sense to me because consent is one of those things that you don't want to put any undue barrier on anybody now. But patients who previously have had a phone call and it had not been billed, now all of a sudden this is a billable. Billable to insurance, and you don't want to have a lot of angry patients at the end saying they're not going to pay for their phone bill because nobody ever told them that they were going to get charged. But there are some real important things to make sure that your patients know they're having a hard time as well, to make sure that they know that these are billable visits. So it does not have to be written consent. That was another thing that went away, which is very timely. It only has to be verbal consent, and the verbal consent has to be documented in your note. So what do you need to put in that verbal consent? These are just, for me, the most important things to convey. The most important thing, this is another thing, this is not informed consent. So there is a legal determination that informed consent has to be done by a physician. However, general consent can be done by anybody. So one way to do this is have your admin staff call the patients that you have. If they verbally consent, document it once that they verbally consent, and then you are covered. The other way to do this is to consent every patient every time, and it's all about how can we do this. The verbal consent must have a copay. So you have to tell them that there are some insurers that will require a copay. Blue Cross Blue Shield has not waived their copay as of yet. Medicare has. But most providers, most providers don't look at everybody's insurance. So if you can, if you're able to look at the insurance beforehand, then you can say your provider has waived copay and eliminate this. If it's Blue Cross Blue Shield, then right now they have not waived the copay. So patients need to know that they will be assessed a copay for this. You need to tell them that these are billable, so insurance will be billed. Very importantly, if you are going to do video, please make sure that you tell the patients to either be on Wi-Fi or to have an unlimited data charge. Video uses about 3 megabytes per second. So for some of your patients who buy data by the minute, this will use up their data very quickly, and they're going to need that. So if the patient says, I can't waste that time, can I do a phone visit? I think that would be appropriate to tell them. But you do not want to have a patient that comes back and says, these were charges for you, aren't you going to pay for my data charges? So I usually tell them up front when I'm assessing, are they even capable of doing video? And this is what we're training our schedulers to do, to make sure that they have the data required and that this is not going to be yet another charge for them. Now, as far as being in a private area, so once again, HIPAA has been relaxed during this time, but you do, from making sure that this is done in the best way possible, I do make sure that our schedulers tell them that they need to be in a private area at the time of their visit. That's very important for the patient. You will only be able to see on your phone. On your phone, you won't be able to see who's in the room. So if you start talking about a patient's HIV and they're on speakerphone, you have no idea, right? So you need to make sure that they are responsible for being in a private area before the phone call. Same with the video, you think you'd be able to see. However, if a patient has their phone like this, you can't see anything behind them. So ask when you're on the phone and when you're on the video, are you in a private area? Is it okay for me to talk about some of your issues? All right, phone visits. So I think it was actually brilliant, and I can't tell Blue Cross Blue Shield and Viva and now Medicaid how much we appreciate this. Video takes a little bit longer to stand up. There's a little bit more setup on the patient's part, on the doctor's part. So phone visits are absolutely the easiest things to start, and everyone is already losing revenue for this. So I would start this immediately, and that's what UAB planned for. That has been primarily what we have done for the first week of this. It's the easiest to get started. The documentation must have verbal consent, and it must meet the level of service billed. So that's very important. You cannot just call a patient and bill. You have to document exactly like they came in person, and you have to meet the same medical decision making. For all insurers at this time, you cannot go above a level 3. Now, as far as video visits, so video visits are harder to set up. And the reason they're harder to set up, and people think they can be easy, one of the most common, even though UAB has a full HIPAA compliant software that is enterprise wide, when they relaxed the HIPAA requirements, people started saying, oh, well, what about FaceTime? And the answer is you can use FaceTime now. You can use Skype, you can use Zoom. FaceTime is a problem because really only your Apple users. So you have to say, well, now I have to know that only Apple users can do it. So that's problem number one. Or you can download it, but somebody has to tell the other providers that, okay, you can use FaceTime. The other problem with FaceTime from an operational standpoint, but right now we're just trying to get through it, is that as soon as you do a FaceTime with your phone, now the patient has your phone number directly, and you don't want them calling, or 1,000 people calling on the same phone that you're doing the FaceTime. So there's pros and cons to each of this. Zoom is inexpensive. There is a HIPAA compliant version of Zoom, but now that has, like I said, has been waived as far as the need for a BAA with these providers. Skype is another way you can do it, but all of those need the patient to download an app to their phone. So what we have done at UAB is our schedulers, now when they're setting people up for any video visits, they are coached on to say the verbal agreement to make sure the patient can do a video visit. And then at that time, they make sure that the patient has downloaded the app necessary for video conferencing. One thing that we all have to see here is that operations. So everybody thinks, even with phone calls, that they're just going to call a patient and the patient's going to answer immediately and everything's going to be fantastic. But it turns out that probably about 30% of your patients aren't going to answer on time. Some of them, it's going to go to voicemail. So everything that can happen at an in-person clinic, like patients showing up late, they can happen over video. So when we start thinking about how we're going to scale this, and basically see the same amount of patients we were seeing before all of this, but see them remotely, you need to start thinking about your operations. Personally, on the phone call, I think it would be best if you had an admin staff call the patient, get them on the phone, and then transfer it so that the providers can have the patient on the phone ready to go for their visit and then move on to the next one. I think that's probably the best way to do it. Also, most providers don't understand that if you're doing electronic charge capture, you have to arrive the patient. So having the admin staff who already has access to the scheduling is a good way to scale this. So the patient gets on the phone, they get arrived in your electronic charge capture, and then they get transferred to the physician is a very efficient way of going through phone visits without requiring or without running into the voicemail, et cetera. This crisis is going to require all of us, and it's going to require all of us to be working at capacity. So really start to think about how are we going to scale. Video visits. So for the video visits, I would always start small. So I would not start on Monday converting every single one of your patients for your first video visit in a half day. And the reason is that this is not as easy as it might seem. Every time some provider has done a video visit, they've realized that they weren't in the right place, or the video quality wasn't good. You got to understand that about 10% of your patients, even if they have the data, aren't going to live in areas in Alabama that have enough cell service or internet service to actually do a video. So what I would recommend, and this is what we're recommending internally, is for your first, at least for your first, do mostly, not your first week, just one clinic. Try and convert 2 patients to video and see how they go. Then the next day more, and the next day more. It's a fast learning curve, but you will become incredibly frustrated if you try and do an entire half day of video without the operations fully planned and without having done 1 or 2. So the benefits of video, it's a lot more clinical data. So you can visualize the patient. I mean, diabetes, for example, you can handle most diabetes over the phone, except for you can't do a foot exam. So you can do a foot exam using telehealth. For me, for nephrology, I can do most of my visit with labs, but I really need to assess volume status. At which point I like to do point the camera at the lower extremities, look for edema. The other thing is that a lot of patients have blood pressure cuffs in the home. You can't get vitals unless the patient has access to that. So we have to start thinking, how are we going to transition much of the needed medical care to the home, including vital signs. All of these, you have to meet medical decision making. All other insurers except Medicare will not allow you. So even with video, Blue Cross Blue Shield or Viva or Medicaid will not allow you to reach a level 4 or 5. Medicare will, but it will only do so with video. All right, so billing, most providers are pretty familiar with the level 3, 4, or 5. I got to tell you, I had never gone back and looked at the level 1 or 2, but now since we're going to be billing these and billing these appropriately, it should be important to see what you can bill and what you need to accomplish during the phone visit to actually meet an appropriate medical decision making. So for a new patients are a little bit more difficult to reach a level 3, 4, or 5 when you're talking about doing a visit in their house. And the reason is, unless you are billing on time. So if you're billing under medical decision making, then what you can do is you need 4 components of the history and physical. That's so there's a chief complaint. There are 4 in the HBI, 4 components, and you need at least 2 review of systems. But you have to meet 3. So you need the HBI, review of systems, pertinent family and social history, and then you need a detailed exam. So you're not going to be able to get to a detailed exam, which is 8 points on a physical exam. Well, it'd be difficult to get to 8 points on a physical exam on video. You could potentially do it. There are ways. But it might be a little bit more difficult. It's just going to be more challenging on the new patients. As far as returns, now returns are actually very simple to get to a level 3. So returns are very simple to get to a level 3, and the reason is all you need is 2 of 3. So when I say 2 of 3, that is history, physical, and medical decision making. So you only need to reach the criteria on 2 of 3. So for history, so one note like this, and we'll go, would be you need a chief complaint, 3 points of the HPI, 1 review of systems. That reaches your 1 component, which is the history. You don't need a physical exam. You do need low complexity medical decision making, which is if you're managing 2 chronic problems, that is very simple to get. So with that, you should very easily be able to reach a level 3 for a return visit. We will get to it, but it turns out that Medicare and Medicaid has viewed these only for established patients anyway. And so for established patients, this becomes relatively simple. But Medicare realizes that there will be a need to see new patients as well. New patients are, although this is for established patients, the OIG has stated that they're not going to audit during at least this early time to try and figure out if the patient was established. So just be careful when billing new patients. But know that if care has to be given, care has to be given. All right, now you can bill on time. Once again, because these are telephone visits, Blue Cross Blue Shield, Viva, Medicaid will only allow you to get to a level 3. But if it is a return visit, that time commitment is actually relatively small. So for a level 1, it's 5 minutes. For a level 2, it's 10 minutes. And for level 3, it's 15 minutes. You must be sure that that you document time. So there has to be a time-based attestation stating that I have spent 15 minutes with the patient, and greater than 50% of that was spent in counseling, which is going to be very easy to do. On the other hand, the new patient visits, 15 minutes, 30 minutes, and 40 minutes is the required to reach those times. So just make sure that you put that attestation if you are going to talk about time-based billing. So once again, this is an example of a level 3 billing on the phone, which is a chief complaint, HPI, 1 to 3 elements, and 1 review of systems, low complexity decision making, or you can put in your note that I spent greater than 15 minutes. That needs to be documented. All right, so charge capture. For those of you working with an electronic medical record, sometimes trying to put some of these codes in can be difficult. Sometimes the codes are actually built in. All EMRs have these levels, but in general, we need to start differentiating. So there's the billing region, and then there's the tracking region. So in general, we do need to start differentiating in-person visits from remote visits. Insurance requires that the remote visits, specifically video visits for Medicare. So it's video for Medicare, and it's video and phone for Blue Cross Blue Shield, Viva, et cetera. They want them to go out with a place of service type 2. So right now, your place of service is the clinic, but for remote visits, ideally, they would go out with a place of service type 2. So I would start working now with your charge capture folks to make sure that these bills go out appropriately. Another way to do this, as many will find, specifically in larger institutions, trying to change electronic medical records can be relatively difficult and time consuming. So since the time is now, if there is a need to go to paper charge capture, it's a lot easier to indicate with a pen, but a lot slower in the back end. So the question is depending on everybody's situation, you'll have to determine, based on your IT and EMR, is it faster for me to start doing paper capture and then submit them later by indicating telehealth on them, or is it faster to actually get these codes added? That's going to be for everybody. But I would, as a physician, before I got into telehealth, I didn't understand any of this. So right now, the to-do list is go to your administrator and say, how does my EMR, how can it capture telehealth billing? So we're working on ways to preserve the workforce. So we're working on piloting ways for providers to do telehealth back to their own facility. So there have been some interesting models proposed whereby if you had a large hospital, you could potentially have part of your workforce doing telehealth visits, part of them in person, and then switch. So every 2 weeks you switch to make sure that even when you're on quarantine, specifically asymptomatic quarantine, which many of us will be, that we are still able to maintain the workforce. And unfortunately, this is what is happening in Italy, which is that every time a provider is quarantined, now you don't have a provider, but eventually you run out of providers. So we're going to have to think a little bit out of the box on how do we make sure that we maintain our workforce, the same amount of providers that are providing care today, while keeping them safe and from everyone. All right, so also another way to use telehealth would be to make sure, for instance, nursing that might be home, everybody's going to need to pitch in for this. So there are potentially ways that a nurse that is at home could participate in video back to their own facility to help the nurses on site do documentation, for example, to make sure that everybody pitches in. All right, so let's see. All right, just some of my things that I've learned in the last week that I just want to make sure that people take home, which is that not everyone can work from home. So this crisis is going to require more workforce than less. So I think people are trying to consolidate workforce, but if you look at what's happening elsewhere, they're going outside of, to other countries to get providers who have just finished training, et cetera, to provide workforce. So there's going to be a significant portion that can work from home and support those who are working in person, but somebody's going to have to come in. So this is kind of our fight. So not every visit can be a remote visit. So I think that there's been the idea that we can transfer every single patient to remote visits. But some people are going to need to be seen in person. So I think that one potential downside of telehealth that we need to make sure that we do not fall into is that if everybody converted every single one of their patients to a remote visit, then what's going to happen is very quickly you're going to realize that there are some things that you just can't do remotely, and the patient needs to be in person. So what you can't do is as an ambulatory provider, send all of those patients to the ER. The ER is going to be overwhelmed anyway. If they're overwhelmed with things that could have very easily be handled in an ambulatory clinic, then we're going to be the worse off. So somebody has to come in. We've heard of, so internally, some ways to do this is you have as many providers at home as possible doing e-visit, but then you rotate out a medical officer on duty to actually be sent patients that need to be seen in person, because we're going to have clinics that are in person to handle the ones that can't. So we need to use telehealth. I mean, arguably the best use of telehealth is to keep patients at home and reduce the spread of disease. But so if you have a clinic, you have an admin staff, the admin staff can help you be more efficient. But if you're able to use telehealth to keep patients who don't need to home, you reduce your exposure. You just don't bring it down to zero while still maintaining a semblance of a workforce to make sure that we can adequately address healthcare needs. All right, so crossing state lines, this is asked very frequently. So the Secretary of Human Resources, Secretary of HHS, has actually removed the state licensing requirement. So you have to hold. So it doesn't mean you can practice anything without a license. What it means is if you're an MD, you can practice as an MD in another state. If you are an NP or a PA, you can practice in another state. So you have to practice at your level, but you don't have to get credentialed in the state at which you're practicing, which is designed to remove barriers. However, that doesn't mean you will get paid in every state that you practice in. So it also means that liability, although it's going to be significantly reduced under the times that we're in, although liability risk is low, if you get sued, you will get sued in the state which the patient is at the time of the home visit, and subject to that state's tort law. So in larger institutions, you may want to run it by your liability folks to see which tort law states they are, well, at least to make them aware that you're going to be practicing medicine in those other states. Billing, so Medicare might be easy, but although the state licensing doesn't pertain, insurers have to have a way for you to bill them, and they need to have a registration, right? You have to be a provider with those insurers. So state Medicaids, you still need to become a provider with that state Medicaid. If you're billing the Blue Cross Blue Shield in another state, same thing. So you need to make sure that, so it's not just licensing. Licensing is part of it. We need to get the care out there no matter what. But you can cross state lines, but that does not guarantee reimbursement unless you have the back end to make sure that where the care that you gave was able to be billed. All right. Quick word on portals and e-visits. So Medicare has allowed for the virtual check-in. The G2012 can be billed through portal messaging. There's also a code, the 99421, 422, and 423. These are codes for portal messaging as well. The thing is in this case, all of these require consent. So now you have, and not every time, but you have to give an expectation of the patient that now when they actually do a portal message, that their Medicare will be billed. I say, so there is no copay for this, but they need to know that their Medicare will be billed. Other insurers, we are working on this, but other insurers do not cover these codes. So this is only for Medicare at this time. It can be verbal consent, and like I said, it's not approved for other insurers. One of my colleagues, because UAB Telehealth has been, or UAB eMedicine as we term it, has been basically working at full speed since last week to try and get everybody up. One of my colleagues said, "Hey, look, this is a marathon, not a sprint," but I tend to disagree. Right now, with the rate at which COVID is increasing, it's actually, this is a sprint followed by a marathon. So, the time is now. Your patients need you now. And also people will look and start realizing you're going to start losing the level 4s and level 5s. Many of your patients are not coming in, and rightly so, to practice social distancing, but that doesn't mean that they don't need care. So unfortunately, this is a sprint, and then it's going to be a marathon. So let's all stay safe while fulfilling our oath. Telehealth is a powerful tool that can help us do just that. But I am one of the most pro telehealth people as possible, but I do want to steer people away from saying that I'm going to just transfer my entire clinic to telehealth. There might be some rare exceptions to that, which is obviously physicians who are in high-risk groups. So physicians who are in high-risk groups over the age of 60, immunosuppressed, pregnant females, type 1 diabetes, those providers, I think that it might be appropriate to transfer all of your visits. But I would encourage everyone to try and find ways to care for patients in your home and help those who are on the front lines. So contact information. I consider myself a resource. So I don't have all the answers, and things are changing. Please, I will try and have the actual slides available. I'll send those to Tiers Porter with the Medical Association of the State of Alabama. Take down my email, or take down my cell. At this point, when you text me, I won't have your information. So please identify yourself. At this point, I'm getting about 300 emails a day. But I am getting to them. I think a good day is when I get them down below 100. So please be patient with answers. If it is not emergent, email me. If it is semi-urgent or just something that's quick, you can text me. But once again, this is the information that I have. This will be downloadable, so try and do as much as possible on your own. But I'm here to help. I think we're all going to have to help each other on this one. So with that, I'm happy to take questions. And I think I already have some. Let's see, let me go back up. All right, so. All right, so one question from M. Stoll: can we document other providers' exam for all patients on contact precautions or just COVID? My understanding is all patients on isolation, because the goal here is to reduce PPE. And so the issue with PPE is that right now we don't have a lot of COVID patients, but unfortunately overnight, every URI that has come in has to have PPE. So we're just going through PPE at a ridiculous rate, even on non-COVID patients. So on your other patients, for instance, the example it gave was a burn patient. Also you can document, but remember, this is only Medicare. So we are, we are all working towards other insurers' adoption of these policies because this is just going to be needed. If we run out of PPE, I think there's going to be worse issues. So it's not just about it's not just about not wanting to go in because a patient is COVID-19 positive. This is about making sure that healthcare is sustainable in the long run by preserving our PPE so we have it when we need it. But right now it is Medicare only. So is there a modifier code that we need to add to the BCBS 99211? Yes, this is a GT modifier. So it's a GT modifier and it's a place of service type 2. Medicare has waived all the modifiers. They just want to get it out. So I think that what we can do is what we have done for ease sake. Unfortunately for providers, we are getting inundated with information. I mean, every day we have 3 emails about COVID. We have different billing. For the administrators in the room, I would try and make this as easy as possible, which is it is a level 1, 2, or 3. Affix a GT modifier to everything. I don't think you're going to get penalized for having a GT modifier when it shouldn't be there. So just a level 1, 2, or 3, and then there might be. Currently, we are doing a back-end edit on phone. So based on our current understanding of Medicare, if it's a phone visit, what we have the providers do is bill a level 1, 2, or 3. And then when we realize that this is a phone visit and we have appointment types to actually cheese those out. So if we realize that as a Medicare patient doing a phone visit, we have a back end edit, but the providers only have to know 1, 2, 3, and then affix the GT modifier. Another modifier you might like is, or might need is the CR modifier, that is catastrophe related. So if you are billing that isolation where you are not going to go into the patient's room on a Medicare patient, then you affix a CR modifier. And a CR just means catastrophe related. And it basically means the only reason that I am not going into the patient's room is that we don't have PPE and this is related to COVID or to a catastrophe. So I would affix a CR modifier to that specific instance, but the GT modifier, that's most insurers, they don't have the requirement. Blue Cross Blue Shield went away from it, but operationally, if you have the GT modifier, it's a way to signal to your billers that a place of service type 2 needs to be added. These are all things that providers shouldn't be worried about. They should be worried about taking care of patients, but we need to communicate with our administrators that we need to make it easy. So when I put level 1, 2, 3 telehealth, that everything just flows so we can get through the patients that we need to. All right, Shawana Clark asks, can you address when it would be appropriate to bill the facility fee? So that's an interesting one. So right now, so what's going to happen, and it's a big deal, which is that in-person visits have always had a facility fee. Telehealth has never had a facility fee. I mean, arguably, the economics of telehealth have always been that you bill a lower rate, but you don't have the overhead of a building and staff that you need. Unfortunately, that's not really true as far as the overhead, because you do have overhead. You have the overhead of the internet. You have the overhead of your schedulers, because you can't just call a patient over the internet. It's just not that easy. The billers, you have a overhead of your EMR. So there is overhead with telehealth. As of now, there is no facility fee. Now, there is a facility fee that historically has been for telehealth. That's called the originating site fee. But that is when the patient goes to another facility. So one example of this is, so if I'm here at UAB and I send my patient to a doctor's office or a county health department, then the county health department gets to bill the facility fee, which was a Q3014, which is about $18 to $25, depending on the insurer. But the facility doing the telehealth got nothing from a facility fee standpoint, right? With home-based telehealth, so right now, virtually, if the idea is not to get patients to go to a facility, it's to keep them at home. So virtually all telehealth at this point is in the patient's home, which means there is no facility fee. I think that there's an argument to be made that even when the patient is at home, there should be a smaller facility fee, definitely a much smaller facility fee than what the patient, if the patient had come in person. But that is currently not supported by any insurer at this time. Now, another flip on things, right, which is that if you are doing telehealth to your own facility, right, so we have a doc who is at home and they are seeing patients here here in the clinic. Well, now all of a sudden there is a facility fee. So you have a clinic on campus and you are outside, or you have a nurse, a person here, and you as a provider are at home. You could actually bill that as an originating site. So that's a little bit different because you are having the patient not in their home, they're actually coming to a medical facility. But once again, the benefit of that is you get to keep the provider safe, or the provider is quarantined and can't let the patients, so if a provider is quarantined at their home and the patient needs some sort of in-person care, injections, things, well, now your clinic is open, but under those circumstances, your clinic becomes an originating site, and you can bill the originating site under those circumstances when the patient is not at home. So I would take advantage, if you are using that model, to actually take advantage of the originating site fee. All right, so another question. Are the testing HCPCS for COVID-19 U001? All right, so only billable by labs? That's a great question, and one that right now I've been reading umpteen things about telehealth billing. I have not actually read all the requirements on billing for testing, but if you email me that question, I can at least point you to resources. I would highly doubt that it's only billable at labs. In general, Medicare and insurers have pulled out the stops about testing, but do not quote me on that. I'd have to look a little bit more in depth at that billing. All right. Cheers Porter says the Medical Association has gotten Kim Huey, an expert in coding, to help with some of the coding guidance. Some questions can be answered in her guidance posted to the Medical Association website. The website is listed there in the chat. All right, McCulloch, can MASA work with all insurance companies to allow phone without video all the way to level 3 or 4? Many of my patients are Medicare or managed care and Medicare and do not have technology for video. I completely agree. Now, I do agree that there has to be some sort of regular quality control on what's a level 4. And right now, the easiest thing to understand is the current billable guidelines. The current billable guidelines would say that for that level 4, you're going to be on the phone for 30 minutes, and you'd need a time-based attestation to say that. Unfortunately, we cannot let, and this, although all insurers do allow for this, it's Medicare that really is, well, let me go back. Medicare is the first one to allow for a phone visit up to a level 3. I think that should be our, MASA should be working with Medicare to change the language in Medicare. It'd be very simple, to allow for audio or visual. So if they just change the audio and visual to audio or visual, then you would be allowed for telephone and video visits. And I think what, unfortunately, Medicare doesn't understand is there is a real potential under that kind of billing guidance that telehealth actually worsened healthcare disparities under the time where the people need us most. Because now it's essentially saying if you do not have the technology in your house, such as an iPhone and data, all of a sudden you have to come in, not practice social distancing, and get infected. I think there's a real problem with making the distinction between phone and video and only allowing video. So I think that's number one, is making sure that Medicare understands that we need both phone and video. The second thing for them to understand and to push for is that we understand we need to meet a reasonable, we need to meet the guidance on what is a level 4, but if we spend 45 minutes on the phone with a patient, that should be allowable, at least as a level 4. But knowing that we will never reach the medical decision-making or the detailed physical exam needed to achieve a level 4 unless we do video. Another thing on the word of disparities, so as the son of a Chilean immigrant who spoke Spanish and but has lived in Alabama for the last 40 years, she is so we have to start thinking about what are we going to do with interpreter services. UAB currently can do 3-way conferencing. What about our hearing impaired patients? So I would encourage you now, when things are in crisis mode, it's just do what you can. But there are some real needs out there for patients who do not speak English and for patients who are hearing impaired. And we have to start working our operations to say, how are we going to meet their need for low acuity issues without unnecessarily compromising them to risk of COVID infection. So Heather Glover, piggybacking on Shawanda Clark's question, is there a code for the collection of COVID-19 tests when sending it out to a lab? Once again, I'm not sure, but that is a great question, and maybe at the Medical Association of State of the Alabama. Sorry, been a long couple of weeks. Medical Association of the State of Alabama. Maybe at that website they have more documentation on that. How does the telehealth work for home dialysis visits? So we've been doing this honestly. So that's something I'm very comfortable talking about because that was my first. I was one of the first, or not one of, I was the first in the country to actually be able to do these visits with home dialysis, which is what my start was. Really, the way that this works is a patient. So there's a couple of models. One is we call the patient at their house. So every individual is going to have to say, does the patient need labs once a month? So that's an important distinction that is usually at the dialysis provider level. At this point, I think that dialysis patients do need labs once a month. You have to think that coming in very quickly for a lab versus staying in a waiting room full of patients is a much lower risk exposure. There is also ways to get labs in people's cars for home dialysis. So one model is you get labs and then you tell the patient to go home and then we'll follow up. So when you're doing the video visit, what I usually do is look at all of the patient's flow sheets. So they're going to have the flow sheet, so you can visualize those. You just have them show you. You could have them take pictures and send. That was never available before, but since HIPAA is a little bit more lax, that could, but you don't need them to. You can just have them focus on their flow sheets. The next thing I do is I have them actually show me their peritoneal dialysis site, which probably should be written up as very challenging. It's very cute to watch my 70-year-old patients try and focus an iPhone on their peritoneal dialysis exit site. It does take time, so you'll have to have some patience in dealing with that. And also, then I have them look at their legs. I have them focus the camera on their legs. They push, and I can determine edema. So you can actually get a pretty good exam. Labs, like I said, one way to do this is just make sure that when they come in for labs, they minimize exposure. Now, each dialysis provider will have their own expectations about what the nursing visit looks like, but most of that can be done over telehealth. Once again, the technology is irrespective. It's just making sure we can care for those most in need. We have bigger issues in dialysis, which is now what do you do for access, for new peritoneal dialysis patients, training that has to be in person for 8 days. So what do you do with the training patient that gets a URI? I mean, there's lots of things that fortunately or unfortunately for instance, Raj Malhotra, who's just an outstanding leader in home dialysis in general, Washington State in Seattle, which is where he's based, was one of the hardest hit. So we have some guidance up front. For EPO in the home dialysis patient, we train our patients to do it themselves. You can actually have nurses witness it at this time. But that's how I would do that. All right, let's see. So it says, how do I bill for Medicare or Medicare managed care for patients in nursing home or assisted living? Unfortunately, I do not know that the assisted living as well. I mainly have focused on the provider billing, but Cheers Porter has said that the policy is with HHS and CMS for the difference. So MASA can help with that. Dr. McCulloch, we are Daphne Family Practice, are reaching out to facilities, and most have the capability in their facility to allow FaceTime via their facility iPad. So yeah, no, I mean, at this point, you use what you have access to. All right, from Sophia. Oh, and that says privately. Yeah, okay. All right. So Dr. McCulloch, back to my question regarding nursing homes. Oh, nope. That's about the nursing homes again. And finally, so can you again go over what payers will accept video or phone communication? So at this point, we've become very easy. All payers will accept video or phone. The only difference, up to a level 3 with one exception, and that is Medicare. So in the current reading of the Medicare guidelines, they will only accept phone for a G2012. So we need to work on them to change that wording to audio or visual. And so I think that's really important. And I don't necessarily know, they're in crisis mode too. So I don't know if they actually did that on purpose, or if they've thought about the disparities that's going to create in our underserved populations. M. Stoll, so wait, I might have missed one. Okay, Brandon Phillips, do you have any experience on performing a wellness visit on telemed? We have not as of yet. One of the reasons we have not, so in non-COVID times, there was a requirement, in order to meet metrics on quality, to have a BMI documented. And that BMI requires a height, it requires weight, and that was not accepted if the patient did it at home. And so although it was one of the first things that was covered in our state, for these wellness visits, there's always the devil's in the details. At this point, you can do a wellness visit, and I think we have to do the best we can. I mean, we still need to make sure our patients aren't smoking. My suspicion is in these times, the amount of smoking will, one of two things. It will either increase dramatically because people are stressed, or it'll decrease dramatically because nobody wants to go out and get a cigarette. So I think that there weight loss, also, I mean, we may have weight loss because people don't want to practice social distancing. But I think that, probably the biggest wellness stack is making sure that people's mental health is in check. I know what it's done to our own providers, me personally. I mean, everybody is stressed to the max. So, increasing the ability to have support groups, things like that, and checking in on your patients is going to be huge. I am very nervous about our isolated patients. They were isolated before all this, and now we're telling people to isolate. So I think there's going to be some real problems. we have a lot to learn from. So, some of the biggest use cases of telehealth came out of major disasters. And one of the disasters, actually, there was, I forget the name of it, but there was a giant earthquake in the Croatia, I forget, no, it was the Balkan states. It was in one of the Balkan states. But anyway, after that, there was a lot of telehealth going on. This was in the 70s to actually help with that. And it turns out that there was the initial wave of the disaster. But the biggest thing was the rates of alcoholism and depression after the disaster with families that had lost everything was probably the biggest health concern. So Alabama already has some difficulties in mental health before. I think all of us are going to have to be able to become, to some degree, mental health providers. That is not something that we will ever be able to handle only with the mental health providers that we have. So just I would be on the lookout. There's the healthcare needs, but there's also going to be a lot of mental health needs that we have. All right, so M. Stoll says, is there any loosening of the requirement as to who can serve as an interpreter? As a pediatrician, most of my teenage patients with Spanish-speaking parents are bilingual and speak English as well as I. I don't think, I mean, this is, I do not think there's any loosening on what can be an interpreter. I mean, the thing about this is you do want to make sure, so as a fluent bilingual speaker myself, I have been in the room where people have been translating. I do think in the ideal situation, so there's the crisis and then there's the moving forward. In the crisis, I don't think it matters. I think that anybody that put a restriction on a teenager who was trying to help their parent out speaking, I think that's I don't think anybody's going to fault that. On the other hand, moving forward, you do have to have some sort of medical understanding of some sort, or at the bare minimum, the providers who are doing the translation, this is even in person, need to explain it in a way that is very, very easy to understand, because not all medical translation gets translated appropriately. So I would just say, just make sure that it is understandable on any level when it's being translated. And then work towards getting an actual medical translator conference in. But for right now, just, do what we can. All right. Cheers, Porter. I will take the interpreter patient question back and try and get some guidance. Where we're really going to have some trouble, as the home of Helen Keller, I do think we need to really start working towards ways that if you don't have the ability to do video conferencing, that we really start working with our champions for the deaf to actually, or the hearing impaired, to actually do this. As somebody who's done telehealth, even with telehealth carts, even in person, coming from technology, the sound coming out of the iPads and the iPhones is just not huge amounts of volume. Luckily, for those who have, so my son has a hearing aid, and now, you can Bluetooth for those who have the fancy hearing aids, you can Bluetooth the sound to the hearing aid, which might help. But that's only going to be for your tech savvy, and for the folks who have the money to pay for that type of hearing aid. Hearing aids are incredibly expensive. So I don't think we can rely on, I think we are going to have some video options for sign language. And I think that probably in the next weeks, that's going to be one of my tasks, is making sure we have that option available at our system level. All right, so Dr. McCulloch, we will continue to express our concern to Medicare. That was Cheers Porter with MASA. Yep, I agree with Dr. McCulloch completely. And I think that, I actually don't think that, I think it's probably more of an oversight on their standpoint. So let me mute everybody. So I think they will come down off of that. There's just, there's no reason why they wouldn't, and it really serves to harm folks if we don't constructively tell them to consider changing their language to audio or video, not audio and video. Okay. So if there are no more questions, like I said, this will be videotaped. I'll try and get it out to everybody. Try and stay as safe as possible. We're going to need everybody on this call. We're going to need everybody even past this call. It's just some tough times. I'm here to help. Okay. So with that, you guys enjoy the rest of your Saturday. Please, if you have providers that are even considering telehealth, direct them to this. Massa will have it. And so make sure they know this is a resource that everybody can use. So appreciate it. Thanks a lot, everybody.